I wanted to remind all the individuals who are about to deliver comments in order, please, again, declare your potential conflicts of interest before delivering remarks. And our first speaker is going to be Dr. John Wang from Bristol Myers Squibb. John?
Thank you, Dr. Brindis. Just a quick sound check. Can everyone hear me?
Indeed.
Yes, great. Thanks so much. So good morning, good afternoon. My name is, as Ralph said, Dr. John Wang, Vice President of Medical, U.S. Medical and Cardiovascular and Established Brands at Bristol Myers Squibb. Just want to thank you for this opportunity to speak, both as a board certified cardiologist and on behalf of Bristol Myers Squibb, to the value of Mavacamten, which is currently under FDA review for the treatment of symptomatic obstructive hypertrophic cardiomyopathy, also known as HCM. Obstructive HCM is a debilitating and life-changing disease, I think, as you've heard, sometimes with symptoms limiting even routine daily activities, substantially impairing health-related quality of life. Currently, there are no available medications that target the underlying pathophysiology of HCM. Surgical intervention can be the final option for patients with symptoms refractory to first-line medications. So therefore, there is a substantial unmet need for novel disease-specific therapies that improve quality of life and potentially slow or reverse disease progression, mitigating the need for surgical intervention. Mavacamten, as you've heard, represents the first pharmacologic breakthrough for HCM in about 35 years, and if approved, would be the first-in-class myosin inhibitor, specifically targeting the underlying pathophysiology of HCM. And as you heard in Explore HCM, all primary and secondary endpoints were met with statistical significance, including clinically meaningful improvements in symptoms, peak oxygen consumption, and quality of life, with emerging data suggesting regression of some of the HCM-induced abnormalities in heart muscle structure and function, which is consistent with the mechanistic and preclinical data. Mavacamten's safety profile, as reported in the peer-reviewed literature, was generally comparable to that of placebo in Explore HCM. So from the outset, BMS has been concerned that ICER's view is premature, given the fast-evolving evidence for Mavacamten. Should Mavacamten receive FDA approval, additional data will become available through peer-reviewed publications. However, even within the specified criteria of this review, ICER's methods remain fundamentally flawed due to two major design decisions: its choice of treatment comparators and its assumptions about mortality and disease progression, which have been mentioned already. First point, ICER's comparison of septal reduction therapy, also known as SRT, and disopyramide with Mavacamten is incorrect and misleading. The SRT patient population in the ICER model was based on the Mavacamten arm of Explore, in which 72% of patients had NYHA class 2 symptoms at baseline. The ICER assumption is that all these patients with NYHA class 2 symptoms would receive SRT, and it's actually inconsistent with the current ACC/AHA guidelines 2020 and ESC 2014 guidelines. As for the disopyramide arm, the baseline NYHA class distribution was based on the Sherrod et al. Paper, which means the patient population in the disopyramide arm differed from the other treatment arms in terms of baseline disease severity, quality of life, and healthcare cost. Furthermore, and I think as acknowledged, there is insufficient data for a scientifically valid and rigorous comparison of the different treatments. Despite recognizing this limitation, ICER proceeded with an inappropriate comparison between the randomized clinical trial evidence of Mavacamten and real-world observational evidence on SRT and disopyramide, because the true treatment effect of SRT and disopyramide relative to Mavacamten are unknown. Second point, ICER ignored the well-documented evidence on mortality and disease progression in obstructive HCM. As seen in the literature, mortality risk increases with higher NYHA class and HCM. The base case model assumed there is no difference in mortality risk by NYHA class. While ICER's scenario analysis attempted to account for this difference in mortality risk, this analysis was based on a sample in which most patients had non-obstructive disease, yet mortality risks in obstructive and non-obstructive disease are known to be different. Contradictory to patient experience, which we heard from Lisa, and cumulative literature, there is no disease progression in any patient after week 32 in ICER's model, while HCM is a heterogeneous disease with very clinical presentation, ICER's model focuses on symptomatic obstructive HCM and mainly in patients with baseline refractory symptoms, despite standard first-line treatment. these patients will likely experience disease progression over their remaining lifetime. Any model that doesn't accurately reflect this disease progression can't accurately predict treatment efficacy. So in conclusion, we are concerned with this premature and flawed evaluation, given the fast evolving evidence for mavacamten and the inappropriate choice of disopyramide and SRT as comparators. ICER's model was further based on invalid clinical assumptions, most notably on mortality and disease progression, that underestimate the disease burden and unmet need that patients face, and undermine ICER's ability to accurately estimate treatment health benefits. These and other issues were detailed to ICER by patients, providers, and professional organizations in previous submissions, and were largely ignored. Here, BMS is reiterating and expanding on these concerns today. Thank you. That's the end of my comment.
Thank you very much, Dr. Wang, for your comments and on behalf of Bristol Myers Squibb. I wonder if any members of the ICER team would like to comment on some of the points raised by John today.
Sure, I'd be happy to. So on the first point, Dr. Wang, about the assumption that the patients getting septal procedures would look like the Explorer patients, and so more class 2 patients would be getting septal reduction than would occur under guidelines. Wouldn't that make septal reduction look worse than it really looks in the real world, so that there's not as much space for improvement, and the mortality from septal reduction look worse, since we're talking about patients who are less sick? And so wouldn't that make septal reduction, as you're suggesting it, look even better than mavacamten?
So I think if you want to look at it purely from a money point of view, I think you're right. What you're saying, though, essentially is that you want to go against guidelines and what the professional organizations have all decided is appropriate therapy. So you're actually recommending inappropriate therapy.
Oh, no, we weren't recommending anything. We were trying to make
no, but if you're actually doing, if you're doing a comparison, I mean, think about it from a patient point of view. If you're doing a comparison and you're saying, or you're doing it from a payer point of view, which I believe is really more your point of view, you're asking actually to, and I think this is in reference to the question that Ms. Gregory or Kimberly Gregory asked, is that you're asking to pre-auth surgery before medication based off cost.
No, we're not. This was just a conservative assumption to be as favorable to mavacamten as possible, as opposed to an assumption that would be negative to mavacamten in the model. It wasn't a
Yeah, but it's ignoring the.
Can I ask you a second question, though?
It's ignoring appropriate therapy. We have to have ground rules that it has to be appropriate therapy. It's not appropriate.
We completely agree.
Okay, so the question in some ways is relatively irrelevant and moot.
Not in terms of the price, but let me ask my second question of you. You suggested that it was unfair that we didn't include a mortality benefit for mavacamten, and I'm wondering if they're expecting an FDA label that states that mavacamten improves mortality in patients with hypertrophic cardiomyopathy.
Yeah, so we're in discussions now with the FDA. It's unclear what that will look like, because these conversations are highly fluid. So I just can't answer that at this time.
Have you published any evidence showing a mortality benefit?
There's no published evidence for this, but as you saw, the biomarkers that have been well correlated with mortality, such as BNP and troponin, did go down with mavacamten.
Okay, thank you.
David, yeah. Are you finished with your key points you wanted to raise?
Yes.
Okay. I think in the interest of time, we need to move on, Dr. Pearson. So let's hear from our patients at this time. And thanks again, Dr. Wang, for your presentation.
Okay, thank you so much.
Okay, Bilar Dowse, you are on.
Thank you. I'm going to minimize the screen, so don't count this as my time. But my conflict of interest, I'm a retired Holcomb person. So please make a correction here. I'm a board director at HCMA, but I am not receiving any funds from Bristol Myers. We are volunteers. Okay. So You can hear my voice? Hello?
Loud and clear, you're doing great.
Okay. So here we go. Good afternoon, everyone. My name is Bilir Daus. I am a patient with HOCM who had to retire early after I was diagnosed 4 years ago. My perspective today is from a patient's point of view, as well as an informed expert with over 25 plus years of experience in pricing, access, drug evaluations, and outcomes, both in the academic medical center and in the pharma industry. I'm also a board director at HCMA. My apologies for my slower speech today, as I have endocarditis. I just got out of the hospital after being an inpatient for 11 days. I'm receiving home infusion antibiotic therapy through PICC line, which will go on for the 6 weeks. So in short, I am very exhausted. However, appearing today was critically important for me, and here I am to provide my voice for the evaluation of Mavacamten. 4 years ago, my HOCM manifested itself after a sudden, uncontrollable asthma attack during an international business trip. 5 months after my diagnosis, due to my severe symptoms and the fast progression of my HOCM, I had to retire early from my job. I am NYHA Class 3. I was given strict medical orders as to what I can and cannot do, started on medication therapy, which became a cocktail of medications and into medical dose escalations to control my symptoms. As a person who never had to take beta blockers and calcium channel blockers before in my life, not only it was very difficult for me to initially handle the impact of these medications and the impact of the daily HOCM symptoms, it was quite difficult to describe what it does to the quality of life of a person. The obstruction pain is very excruciating. It took a good 3 years to understand what triggered some of my symptoms and how to cope with them when they appear out of the blue. Given the way HOCM manifested itself, led me to make major lifestyle changes, which also had a huge impact on others in my family. There's no way I could have continued performing my job at the level I was performing had I not retired early. This had a major economic impact on my family and my life plans. These details I'm sharing with you are actually essential in understanding the social and indirect costs that must be taken into consideration when creating models to determine what is a meaningful improvement if a new medication is going to be added to the treatment, and if the magnitude of the improvement is meaningful enough to improve the quality of life of the patients. ICER highlights these in section 5 titled Contextual Considerations and lists all of the attributes as a must to be considered when evaluating the value of effectiveness of Mavacamten. These contextual considerations make up the core theme in all of the questions that we deliberated today and voted on today. However, what stuck out for me from the very beginning is the absence of any of these considerations in ICER's models. I highlighted my major concerns regarding the models in previous feedback sessions, with the absence of any social and indirect costs in any of the models and assumptions. And even after rewording the questions, the conclusion still is there is no sufficient data for any of these questions to be answered. In conclusion, I do not feel adequate data appears in the ICER report to achieve a meaningful patient-centric opinion on the value of Mavacamten. With so many clinical unknowns and with so many inaccurate non-real world pricing assumptions and utilization rates, especially in the budget model, it is opening the doors for barriers to access. I urge all of you to please consider the following questions as you deliberate and vote today. If we limit access to innovative medications due to affordability barriers by assigning arbitrarily chosen high price points, because you can, it's an orphan drug, which then leads to cost sharing schemes introduced by payers, they can do that because it will be based on their own budget impact models, Knowingly, as a society, we're pushing patients either to bankruptcy or GoFundMe options. Is this what we call American medical innovation and advancement of care? This is a novel first-in-class drug. The current clinical trial data is based on a limited time, but promising. More studies and also actual patient experiences are needed to fully understand the long-term benefits of the medicine. If patient experiences are limited due to affordability barriers, how are the healthcare providers going to learn and gain critical information if patients cannot be adherent to their treatment protocols due to cost?
Bill, are you on your last statement?
Yes,
here?
I have just like 2 statements. Give me a minute. What is the impact of these barriers on future innovations and gaining evidence-based
Bill,
patient
I have to,
outcomes?
and certainly we have to make sure all patients have an opportunity. I want
Okay,
to
let
thank-
me finish. Let me finish my statement, then I'm closing it right now. But every patient doesn't have endocarditis right now, so please give me a minute. All members who are going to vote on these models by ICER to determine the value of Mavacamten, I ask you to really examine your conscience and ask yourself, do I have sufficient clinical and contextual data to be able to answer the questions in front of me to accurately determine the value of Mavacamten for patients? Thank you for the opportunity to express my
Thanks a
concerns.
lot, Bill, and thanks for being
And
here.
please vote carefully and thoughtfully. At
Okay.
the end, we're talking about patients' lives. Thank you.
Thank you so much. And particularly considering your illness, and I hope you recover totally quickly. Our
I
next
hope
speaker
so.
is going to be Gwen Mays.
Hello, I hope you can hear me. My name is Gwen Mays, and I have obstructive hypertrophic cardiomyopathy. As I mentioned earlier, I serve as an independent consultant to HCMA. I'm also a writer and consultant to Edwards Lifescience, Paragonics, and Natural Cycles. By training, I'm a cardiothoracic PA, lawyer and government relations expert. I currently live in Annapolis, and I'm here testifying today on behalf of my own experience. There's very little I'm going to be able to say that is going to be able to capture what it's like to walk in my shoes or know what it's like to experience your heart fluttering and jerking like a fish tossed on land when all you're doing is sitting at church. But that is what I lived with. Regrettably, the cost of overwhelming impact of living with HCM, what you refer to as contextual considerations, can be acknowledged, but it cannot be measured. It can be, nor can it be mathematically calculated. That is always a challenge for patients. Hopefully you've read my public comments, all full 8 pages of them, but just very briefly for those who have not. I've lived a lifetime that is now 65 years with symptoms which became pronounced to me at the age of 12 when I collapsed on a dusty football field in Eastern Kentucky attempting to complete the President's Physical Fitness Award. By high school, I was fainting when I gave blood. In college, I danced too much and fainted. And officially diagnosed with IHSS in 1988 at the age of 32, the first thing a cardiologist said to me was, "You will have a shortened life expectancy." On that day, I began the hardest journey of my life, and that was to learn to live as full a life as possible while knowing that I could die suddenly at any minute. Yes, my cardiologist said, even if you're doing nothing more than ironing your clothes. I'm extremely grateful that today there are so many treatment options and look forward to Mavacamten fitting into our treatment course. Centers of Excellence have literally saved my life. Time doesn't permit me to explain, obviously, what 65 years of living with this condition has meant to my physical and emotional well-being. But I can guarantee you that any question that you have in your mind right now, or you have reading this report, the answer is from a patient's perspective is yes. Yes, HCM has significantly affected my choice in career, where I live, my emotional well-being, whether I'm in therapy or not, my educational choices. It has affected my sleep patterns, what I eat, whether I became a mother or not, advised against to many years ago. It affects my ability to drive, my vacation plans, my sex drive. It affects how much I exercise. And also it affects how I learn over the years to keep my wits about me When I have 6 PVCs in a row, knowing my cardiologist has always said I would lose consciousness if it ever reached 7. I've humanized my heart, coddling it, please slow down, demanding it, please do the right thing. Symptoms of HCM vary and are sporadic. Just in the past few weeks, I've suffered new indications and new symptoms. Just since ICER began this report, I have spent 4 days in a fib with heart rates of 120 to 150 beats a minute, leaving me so fatigued I could not go to the grocery, I could not make my bed, and I was too scared to drive. 2 weeks ago, I was cardioconverted. It was not my first time. Also, over the past couple of months, I've seen a 50% increase in my left ventricular pressure gradient. That is the highest it's been in 6 years, but not the highest it's always been. If you've read my comments, I tracked my gradient since 1995, has been the lowest of 22. It's also been a high of 87. So my decision right now as my health declines is what will lie ahead of me. I am tracked by a local cardiologist. I am also at a local Centers of Excellence and at Mayo Clinic, where I will go next month to be evaluated for cardiac septal myectomy. I look forward to understanding better where Mavacamten fits into this decision-making. I will be reevaluated as to my age, my overall health condition, but no one has been able to answer to me the impact of now having AFib off and on for the past 5 years comes into play, nor do they have any evidence of how it will be interplayed with the drugs that I've been on now for over 35 years. These are hard decisions ahead of me. I look forward to working with this organization and better understanding what I've experienced in the past and the opportunities for better health in the future. Thank you.
Gwen, thank you very, very much for those eloquent comments, which really gives CTAF a great feeling with patients such as yourself with the disease. Thank you so much. Our next speaker is going to be Kent Sperry.
Thank you for having me. My name is Kent Sperry. I live in Beulah, North Dakota, where I pastor Prince of Peace Lutheran Church, and I was diagnosed with HCM about 11 years ago now. Even though my father was diagnosed with it a couple of years before me, and even though the doctors knew what to look for, I was repeatedly told that I was fine, even after experiencing the symptoms of this disease. It took a doctor who was new to my area, who had been previously working at Mayo Clinic, who was opening his own practice, and it was he who identified it. Not long after my diagnosis, I moved to North Dakota. I immediately established myself as the patient of a cardiologist an hour away from home for ongoing monitoring and treatment. There was no one closer I could see. But about a year later, when my symptoms suddenly became worse for no apparent reason, he refused to even make me an appointment. It was then that I sought treatment at Mayo Clinic and became familiar with the work of the HCMA. I learned very quickly how important it is to have a specialist who works with this disease on a regular basis. The care that I now receive is wonderful, even though it's not convenient in the least. For me, receiving this care means that I have to drive about 9 hours one way. It necessitates that I take the time off work to do so, and it usually involves a stay of several days in a motel. And this trip is made on a regular basis, not only for myself. Shortly after my first contact with Mayo Clinic, I was gene tested. The gene responsible for my condition was identified, and this enabled us to test my 6 children to see which of them had also inherited this gene. It meant a fight with my insurance company to have this approved, but we learned that 3 of my 6 children have this gene. This means that not only am I seen at Mayo Clinic to monitor and to treat my condition, my children are also monitored there on a regular basis so that we can know if they develop HCM and to treat it from the very beginning. Some years we've been able to make this trip and to see our doctors at the same time. Other times, however, it means more than one trip. As uncertainty is the name of the game with HCM, I recently experienced a worsening of my condition. For several years, my condition was stable and successfully treated with medication. We changed the dose a few times to keep me feeling well, but my doctor didn't believe I would ever need more aggressive treatment. However, about a year ago, my symptoms drastically worsened. My medication was increased one last time. I was told that I was maxed out on that drug and it still wasn't doing the job. After being seen once again at Mayo, it was discovered that my septum had grown 8 to 9 millimeters and that I was now severely obstructed. So something had to be done. My options were to join the trial of the very medication being discussed today. However, because of the distance and the requirements of the trial, it was determined that it would be very difficult for me to take part in it. I could also try a different medication in combination with the one I was already on, but my doctor believed the chances of this helping me to be slim. The last option presented to me and the one he recommended was surgery. So about 5 weeks ago, I traveled to Mayo to have a septal myectomy. Again, this involved the long drive, a longer stay in the motel, especially for my wife, and the surgery itself. Had it been easier, I believe that I would have joined the trial. Had the drug been available, I more than likely would have tried it before submitting to surgery. After all, the emotional toll of putting yourself in a position to have your chest opened up, your heart stopped, and a piece of your heart literally cut out is great. And even knowing that it was the right thing to do, the worry that it caused as I awaited the procedure was intense. And this was true even knowing that I had a fantastic surgeon at a great hospital and that the risks in a high volume center are very low. From my experience, getting proper medical care for HCM can be both difficult and expensive. Even with the help that insurance provides, this remains the case. While I've made the necessary sacrifices to obtain the proper care for myself and my children, I believe it important to have medical treatments that are accessible to everyone who are struggling with this condition. And my hope is that should they develop HCM in the future, my children will also be able to affordably access the needed care. Thanks a lot for your time.
Pastor Sperry, those were incredible comments, really giving us a perspective of the burden of disease, the issues of going to centers of excellence, and also the genetic manifestations for your family. Thank you so much for your comments.
Absolutely.
Our next speaker will be Nyiah Grooms.
Hello, can you hear me?
Perfect.
Hello, my name is Nyiah Grooms. I'm an African-American mother, lawyer, and caregiver to twins. My twin son, Hassan Grooms, has HOCM, and his twin sister could ultimately test positive for HCM. So we hold our breath every 3 years as she gets tested for the disease. In my profession in healthcare law, I've written the evidence of coverage for health benefits, RX riders, and cost shares for health plans for Maryland, DC, and Virginia. When my son was diagnosed with this disease at 15 years old, I immediately was inundated with numerous appointments for MRIs, EKGs, and my son was placed in a special study at NIH to explore his heart genetic mutation. All this was an enormous amount of time, paperwork, and coordination of care through referrals and appeals. If I wasn't educated, this would have been an even bigger nightmare. More about my son Hassan. He had a scholarship to play basketball in private school since 8th grade and traveled the country playing AAU basketball. And on one horrific day had an asthma attack. That asthma attack led us to understand that he had HCM and saved his life. We were lucky enough to have this diagnosis happen because there's a fact that young African-American athletes die of hypertrophic cardiomyopathy more than any other subgroup. That is why life-saving medication has to be reachable and affordable to diverse and marginalized communities, and the care has to be able to be attainable to underrepresented individuals. My son initially was cared for at Children's Hospital because that is where the health plan directed us. The hospital's care plan was to do experimental tests on my son after fibrosis in his heart was detected. Before agreeing to this experimental surgery, I researched and found HCMA. The organization informed me that there were Center of Excellences for my son's disease. I didn't want my son to be a guinea pig at all costs, and that surgery could have killed him even sooner. I immediately researched and got my son's medical care switched to a center of excellence, which is now required an hour drive to and from to receive his care. As a caregiver searching for life-saving answers for my son, I've had to endure the possibility of losing my child to the disease, to a disease, and so I fight. One such fight was that the doctors provided my son with medication and indicated he needed a portable defibrillator. His disease had not progressed enough for the implantable device. The evidence of coverage said that the defibrillator was covered. However, the health plan pushed back. With my legal education, I pushed back. And I was concerned because the out-of-pocket expense for a portable defibrillator was out of reach. Ultimately, I won the case and got a defibrillator for my home, but paid the cost of losing my job. I then had to frantically find insurance and utilize the healthcare exchanges to ensure my family and myself would have insurance at a specified price point. My son is now a freshman in college, and with college, we've had to work with accessibility services and the American with Disabilities Act for a safer place for my son. He required a single room and several defibrillators being added to campus, as well as an emergency plan in case an SCA event occurred. This is the kind of advocacy a mother has to do for her sick child. Co-pays, co-insurance for medication or doctor visits are always evaluated and needed as more care is needed at any given moment. FMLA, or Family Medical Leave Act, is always necessary as a parent of a child with a genetic heart disease. My son's life matters, and if you can provide a medication that is attainable and reachable for him, it would be life-saving. I implore you to understand the economic impact of an expensive life-saving medication for my son. His options for the future are surgery or medication that can make a difference. I would prefer the least invasive care, which is medication. Further, by age 26, my son will have to muster enough strength to get his own medical plan with a pre-existing condition and be able to get health care to sustain his life. Do no harm here and create a drug at a price point that is reachable for all and able to make a life-saving difference for my son and others with this disease. Thank you for taking the time to hear our story. We simply need adequate access to Mavacamten and not to be shut out of a possible future medication due to the enormity of a cost. I appreciate your time.
Nakora, your comments were incredible, thoughtful, and you could advocate for me anytime. You do a great job, and also highlighted the burden, if you will, of a caretaker, a caregiver in terms of family. So thank you very much. Our last comments will be from Lisa Sauber.
Hello again. I've given my disclosures at the top of this talk, but the HCMA, my employer, does receive sponsorship from Bristol Myers Squibb, Cytokinetics, and some genetic testing firms as well. That's pretty much it on my disclosures. Good afternoon. I am the founder and CEO of the Hypertrophic Cardiomyopathy Association, a patient organization formed in 1996. But from 1989 to 2005, I was employed as a health plan administrator for a private plan. So I can have good arguments with myself all the time. I come from a 100-year history of hypertrophic cardiomyopathy in my family. I am an HCM survivor of a stroke, endocarditis, 5 implantable defibrillators, multiple medical therapies, a proud participant in clinical trials, and a heart transplant recipient. 26 years ago, my sister Lori's sudden death at the age of 36 began the work to create the HCMA. Lori was a casualty of mismanagement of HCM. I currently have 8 family members living with HCM, and my larger HCMA family serves over 15,000 families in 52 countries. The HCMA has helped to develop and support 43 Center of Excellence programs. You can read our mission at forhcm.org. HCM used to only get the headlines when a young athlete died suddenly, creating the narrative that this was a fatal problem for young adults or young children. The reality is this is a common genetic disorder impacting approximately 1 in 250 people worldwide, which is an estimated nearly 1 million Americans. And it can have a highly variable presentation from mild to severely debilitating, as you've heard a little about this morning. Sadly, only 15% of those with HCM are in actual treatment for it today. Adding to the complexity, HCM has had over 75 names given to it, and it's since 1959. Each specific anatomic variation of expression of hypertrophy has led to some significant confusion in nomenclature. What HCM patients want and need is to live the best quality of life possible with a chronic, life-threatening heart condition. They want proven treatment options that are meaningful to them and provide stability in their symptoms and lead to a more predictable quality of life. Mavacamten's early trials show that this can be achieved for some people. As of today, there are no labeled indication drugs explicitly designed for HCM targeting the underlying mechanism of the disease itself. And that's why we're here today. Mavacamten is a very different drug as it targets the previously undiagnosed or unmanaged mechanisms behind HCM, specifically the myosin heads and the cardiac sarcomere. Data related to the use of data related to the off-label use of disopyramide in HCM should be approached with the understanding that I mentioned earlier today. Nor-CR, the controlled release mechanism, has not been in stable supply for at least a decade and is currently out of stock worldwide. And the generic requires dosing every 6 to 8 hours, creating quite a challenge for young people on these medications. The average age of diagnosis for HCM is about 40, but the symptoms appear about a decade earlier, which is a critical point to remember when looking at the clinical trial data, which looks at a much older population. Patients are left to manage with drugs that are used for other forms of heart disease because we don't have any labeled indication drugs. Other treatment options such as septal myectomy or catheter-based alcohol septal ablation techniques are proven therapeutic options for the right anatomies when done at high volume centers. Patients may want to use medication other than invasive therapies due to many reasons, and it might be for long periods of time or short ones. Childcare issues, work, major life events, caring for elderly parents, career implications are just a few of the reasons why people may not want to go to an invasive therapy so quick because they require extensive time off of work. These other treatments are very economically beneficial. We've seen the data on that, but there's more to cost than just the dollars and cents. It's the risk of life and the time that patients must need to get these treatments. It's important for you to understand that not all HCM is the same. The HCM is a spectrum of disorders where there are many mimickers, and they have their own underlying genetic cause, such as Danon disease, Fabry's disease, amyloidosis, Noonan syndrome, and others. Many of these mimickers of HCM have their own labeled indication treatments, and it's critical to get them into the right hands of the right people. That is why going to a center of excellence is critical to get to the underlying cause of why your heart appears to have hypertrophic cardiomyopathy. I want to also bring to your attention that we are very early in our understanding of the use of this particular agent, Mavacamten, in the world population of those with HCM, as it's only been tested in about 300 people worldwide. So to discuss the economic impact, I do feel is a little premature. We simply don't know how many patients are going to be impacted by this drug. We do know that the ICER report does not address many of the contextual considerations, which Biller, Gwen, Ken, and Nikora have addressed here today. I can assure you that patients want access to drugs like Mavacamten. That is why we want a chance to try a drug that's been designed specifically for them. We have the right to try, you know that term. It applies beyond unproven therapies. We believe that when it comes to myosin inhibitors, this concept must be applied once it hits market. Please ensure that HCM patients have an opportunity to access myosin inhibitors like Mavacamten with a favorable review and formulary placement that leave it accessible to the masses. Thank you.
Lisa, thank you very much for your very thorough and thoughtful comments. You're obviously a terrific advocate for the hypertrophic cardiomyopathy patients here and abroad. So thank you very much. And I want to thank again all who commented here during this period, particularly the patients. You've made our discussion today much richer. And we thank you so much for taking the time out on your busy schedules to inform our panel. So Steve, I'm going to turn this over to you. And again, thanks everyone for your comments.